Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Anticholinergic agents are a diverse group of substances that function as either primary or secondary anticholinergics. The intoxication caused by these agents is quite common, accounting for approximately 15 to 20% of cases involving acute poisoning with delirium. The toxic mechanism involves competitive antagonism of acetylcholine at receptor sites, primarily at muscarinic receptors. This results in a characteristic set of symptoms known as the anticholinergic toxidrome, which can be summarized by the phrase, mad as a hatter, blind as a bat, red as a beet, hot as a hair, dry as a bone, full as a flask. This toxidrome includes central nervous system effects such as delirium, hallucinations, and confusion. Peripheral effects encompass pupil dilation, flushed and dry skin, increased body temperature, rapid heartbeat, and urinary retention. While these effects define the toxidrome, severe complications often arise from additional properties of certain agents, such as sodium channel blockade seen in tricyclic antidepressants and some antihistamines. Diagnosis is primarily clinical in nature, as confirming the toxidrome with physostigmine can be challenging. Management involves supportive care, including treatment of agitation and delirium, as well as addressing any complications. Physostigmine is considered the preferred treatment for central delirium when no contraindications are present, demonstrating higher efficacy in reversing delirium and reducing the need for intubation compared to benzodiazepines. Benzodiazepines are typically used to manage seizures. In some cases, alternatives such as rivastigmine and dexmedetomidine are utilized. Anticholinergic intoxication is a very common form of poisoning. It often occurs due to suicidal attempts, recreational use, or accidental exposures. This type of poisoning is responsible for approximately 15 to 20% of all hospital admissions for acute poisoning that presents with delirium. In the year 2014, Poison Control Centers in the United States reported more than 99,000 cases of exposure to substances with anticholinergic effects. Although many exposures are unintentional, serious toxic effects are frequently associated with deliberate ingestion of certain medications, such as cyclic antidepressants and atypical antipsychotic drugs. Here are 10 brief learning objectives for this content. First, learners should be able to classify anticholinergic agents into two categories: those that primarily act as anticholinergics and those with mixed effects. They should also be able to provide examples for each category. Next, understanding the epidemiology of anticholinergic intoxication is essential. This includes recognizing how common this condition is and identifying its typical causes. Furthermore, learners should be able to explain the primary toxic mechanism of anticholinergic agents. This involves a focus on competitive antagonism at muscarinic acetylcholine receptors, while also differentiating this from the blockade of nicotinic receptors. It is important to be able to list the characteristic signs and symptoms of anticholinergic toxidrome, utilizing the mnemonic MAD as a hatter, and to distinguish between central and peripheral manifestations. Additionally, understanding the crucial toxic properties of certain anticholinergic agents, including sodium channel blockade, is vital, as these can contribute to life-threatening complications. The diagnostic approach to anticholinergic intoxication should also be outlined, emphasizing the importance of clinical assessment, essential laboratory studies, and the significance of an electrocardiogram. Differentiating anticholinergic toxidrome from other conditions, such as sympathomimetic intoxication, is important for accurate diagnosis. Furthermore, the role of physostigmine as the treatment of choice for central antimuscarinic delirium must be described, including its mechanism of action, benefits, and critical contraindications. The objectives also include evaluating the appropriate use of benzodiazepines in cases of anticholinergic intoxication. These medications are useful for initial sedation and seizure management, but have limitations when it comes to reversing delirium. Lastly, learners should understand the role of alternative and supportive agents like rivastigmine and dexmedetomidine, including their mechanisms, indications, and the advantages and limitations they present in managing anticholinergic delirium and agitation. The toxic mechanism of anticholinergic substances primarily involves their ability to competitively block acetylcholine from binding to its receptors. This action prevents acetylcholine from activating its receptors, which disrupts normal cholinergic neurotransmission in both the central and peripheral nervous systems. As a result, the communication within these nervous systems is impaired, leading to various toxic effects. Muscarinic acetylcholine receptor blockade is a critical and frequently encountered clinical phenomenon, so much so that the term anticholinergic toxidrome is often more accurately described as antimuscarinic toxidrome. When these receptors in the brain are blocked, it results in distinctive central nervous system symptoms such as confusion, restlessness, agitation, mumbling speech, and picking at imaginary objects, a behavior known as carphologia. Hallucinations may also occur, varying from mild agitation to severe behavioral disturbances and delirium. Peripheral effects of antimuscarinic activity include dry skin and mucous membranes, skin flushing, dilation of the pupils known as mydriasis, loss of the eye's ability to accommodate for near vision, increased heart rate, elevated body temperature, urinary retention, and reduced bowel sounds. These effects tend to be dose-dependent. At lower levels of receptor antagonism, there may be a reduction in sweating and secretions. Moderate levels of blockade can lead to increased heart rate and pupillary dilation. When the blockade becomes more extensive, it may cause urinary retention and decreased activity of the gastrointestinal tract, resulting in gastric and intestinal atony. Nicotinic acetylcholine receptor blockade is less common in typical anticholinergic poisoning cases. However, significant blockade of these receptors can lead to neuromuscular paralysis. This condition is usually associated with the use of certain muscle-relaxing agents, such as depolarizing agents like succinylcholine and non-depolarizing agents like pancuronium. Additionally, envenomation by specific alpha neurotoxins found in some elipid snake species can also cause such blockade. The ability of an anticholinergic agent to cause central toxicity depends on its chemical structure and its capacity to cross the blood-brain barrier. Tertiary amines such as atropine, scopolamine, and physostigmine are able to easily cross this barrier, making them more likely to induce central anticholinergic effects. In contrast, quaternary ammonium compounds like neostigmine and ipratropium do not readily cross the blood-brain barrier, which reduces the likelihood of central anticholinergic effects. The severe adverse effects and life-threatening complications associated with many anticholinergic agents are often a result of their other physiological properties rather than their anticholinergic effects alone. It is important to recognize this distinction, especially in cases of large ingestions. For example, tricyclic antidepressants are particularly toxic because of their ability to block alpha-adrenergic receptors and sodium channels. These effects contribute significantly to their cardiotoxicity and risk of seizures beyond their anticholinergic properties. In cases of overdose, using physostigmine is generally not recommended as the potential benefits are outweighed by the risks. This is because physostigmine can exacerbate life-threatening cardiotoxicity caused by sodium channel blockade. Similarly, first-generation antihistamines can cause cardiac effects by blocking sodium channels, which can lead to widening of the QRS complex and ventricular dysrhythmias. They can also block potassium channels, resulting in QT interval prolongation and torsade de pointes. Some of these antihistamines also act as serotonin reuptake inhibitors or as agonists at postsynaptic 5-HT1A and 5-HT2A receptors, which can contribute to the development of seizures. In essence, the toxic mechanism begins with competitive receptor blockade, but expands into a complex interplay of various pharmacological actions, particularly with xenobiotics possessing mixed effects. Anticholinergic agents encompass a wide range of substances that can be primarily anticholinergic in their action or exhibit anticholinergic activity as a secondary effect. Agents that predominantly function as anticholinergics include medications such as atropine and glycopyrrolate. Atropine is notable for causing mainly peripheral effects at lower doses, while higher doses may produce central effects. Medications used to treat bladder spasms, such as darafenacin, fesoterodine, flavoxate, oxybutynin, solifenacin, toltrodine, and trospium, also fall under this category. For irritable bowel syndrome, drugs like dicyclamine and hyoscyamine are employed. Scopolamine, another anticholinergic, is used as an antiemetic and antixylagogue and is a primary tropane alkaloid found in plants like Jimson weed. In the management of Parkinson's disease, medications such as benztropine and trihexyphenidyl utilize their anticholinergic properties. Ophthalmic preparations, including anticholinergic eye drops such as atropine and cyclopentolate, are used to dilate pupils but can, in rare cases, lead to systemic toxicity. Additionally, many natural plants, especially various nightshade species like Atropa belladonna and Jimson weed, contain tropane or belladonna alkaloids with anticholinergic activity. Agents with mixed effects, including anticholinergic activity, encompass a variety of medication classes. First-generation antihistamines are a significant group that includes brompheniramine, carbinoxamine, chlorpheniramine, clemastine, cyperheptadine, dimenhydrinate, diphenhydramine, doxepin, doxylamine, hydroxyzine, meclizine, and triprolidine. Diphenhydramine is particularly notable as it is one of the most commonly used medications in the United States, making it broadly available and often leading to exposure. Tricyclic antidepressants are another class with notable anticholinergic effects. These include medications such as amitriptyline, clomipramine, desipramine, imipramine, nortriptyline, pertriptyline, and trimipramine. In addition to their anticholinergic activity, these agents also possess sodium channel blocking effects, which contribute significantly to their toxicity. Muscle relaxants like cyclobenzaprine and orphenadrine also exhibit anticholinergic activity. Furthermore, certain antipsychotic drugs, both typical and atypical, demonstrate this property. Typical antipsychotics include chlorpromazine, flufenazine, loxapine, perfenazine, thioridazine, and trifluoperazine, while atypical agents such as olanzapine and quetiapine also show anticholinergic effects. It is important to recognize that many xenobiotics rarely possess a single pharmacologic action. For instance, doxepin antagonizes multiple receptors, including muscarinic acetylcholine receptors. The combined use of more than one drug with anticholinergic effects can significantly increase the risk of toxicity. Diagnosing anticholinergic toxidrome, also known as antimuscarinic toxidrome, primarily depends on a thorough clinical assessment. This is because specific laboratory tests often have limitations and may not definitively confirm the condition. The presentation of this toxidrome can vary widely among patients. However, healthcare providers can identify it by recognizing a group of characteristic signs and symptoms that commonly appear together. These signs and symptoms serve as the key indicators guiding the diagnosis. The clinical presentation of anticholinergic intoxication is characterized by a distinct set of signs and symptoms. This collection of symptoms is commonly referred to as the anticholinergic toxidrome. It is a frequent clinical occurrence, with cases of anticholinergic delirium alone potentially accounting for 15 to 20% of all admissions due to acute poisoning. The classic mnemonic describing the anticholinergic toxidrome succinctly captures its effects on multiple systems. Mad as a hatter, blind as a bat, red as a beet, hot as a hair, dry as a bone, full as a flask. This phrase refers to the profound central nervous system and peripheral manifestations observed in affected individuals. In terms of clinical presentation, the central nervous system effects are particularly notable. The phrase mad as a hatter describes the prominent mental status changes that patients typically exhibit. Most often, patients present with agitated delirium, which can include hallucinations, usually visual, but sometimes auditory, along with incoherent speech, confusion, disorientation, and purposeless movements such as picking or grasping at the air or objects, known as picking or grasping movements. In more severe cases, these symptoms can progress to seizures or coma. Additional central nervous system effects reported in cases include amnesia, anxiety, loss of coordination, difficulty speaking clearly, involuntary movements related to the extrapyramidal system, lethargy, paranoia, psychosis, spontaneous muscle jerks, tremors, and stereotyped movements involving repetitive gestures. It is also important to recognize that central nervous system effects, especially delirium, can persist even after peripheral symptoms have resolved. The central anticholinergic syndrome may occur without any peripheral manifestations, which can make diagnosis particularly challenging in the absence of a clear history of exposure. The effects of anticholinergic agents on the body are often described using vivid phrases. For instance, blind as a bat refers to pupillary dilation, known as mydriasis, which can cause blurry vision and sensitivity to light or photophobia. The phrase red as a beet indicates flushed skin, while hot as a hair describes hyperthermia, a condition that can become severe, especially when combined with agitation and impaired heat dissipation due to reduced sweating. Additionally, the expression dry as a bone signifies dry, flushed skin and dry mucous membranes, including the mouth, armpits, and skin. This dryness results from the inhibition of sweating, a typical effect of anticholinergic agents, leading to a condition called anhidrosis. Recognizing this dry skin is crucial in differentiating anticholinergic toxidromes from sympathomimetic toxidromes, where sweating or diaphoresis is usually observed. The phrase full as a flask refers to urinary retention. Tachycardia, which is a rapid heartbeat, is a common cardiovascular finding. Hypertension or high blood pressure may occur due to the antagonism of acetylcholine-induced peripheral vasodilation. Conversely, agents that have sodium channel or alpha-adrenergic antagonistic properties can lead to low blood pressure or hypotension. Other peripheral signs associated with these conditions include diminished bowel sounds, which may indicate an ileus or constipation, and peripheral vasodilation, or widening of the blood vessels. The severity and variability of effects caused by these agents are often dependent on the dose administered. Typically, peripheral effects occur at lower doses, while central effects tend to emerge at higher doses. Although anticholinergic effects are common, more serious adverse reactions can occur, especially with larger exposures. These severe effects may result from other pharmacologic properties of the agents involved, such as blocking alpha-adrenergic receptors or sodium channels. For instance, certain medications like tricyclic antidepressants and some antihistamines can cause these effects. The anticholinergic toxic syndrome can be a component of other poisonings, such as those involving tricyclic antidepressants or a combination of antihistamines and acetaminophen. In a carefully controlled clinical study of artificially induced central anticholinergic toxicity, 3 overlapping phases were observed. The first phase, induction, was characterized by predominance of peripheral effects. This was followed by a stupor phase marked by somnolence, restlessness, ataxia, hyperthermia, and hypertension. The final phase, delirium, involved symptoms such as memory loss, confusion, incoherent speech, and hallucinations. Certain agents can cause anticholinergic toxicity, which can lead to symptoms such as widening of the QRS complex on an ECG, low blood pressure, and seizures. Diphenhydramine, a medication that is widely available, is a common cause of unintentional anticholinergic poisoning. Cyclic antidepressants are more often involved in intentional overdoses and tend to result in more severe toxicity. Seizures are reported in roughly 3 to 30% of such cases, although the exact underlying mechanisms may not be solely due to their anticholinergic effects. Plants like Jimson weed, also known as Datura stramonium, frequently cause anticholinergic symptoms. Patients affected by these plants often exhibit dry mucous membranes and dry skin, symptoms that are observed in a high percentage of cases. Additionally, certain types of mushrooms containing the compounds muscimol and ibotenic acid are sometimes mistaken for causing anticholinergic poisoning. However, these mushrooms primarily influence the gamma-aminobutyric acid and glutamic acid neurotransmitter systems, which are different from the pathways affected in anticholinergic toxicity. Clinical diagnosis of anticholinergic intoxication is often made based on a detailed patient history, focusing on exposure to potential toxins and the presence of characteristic signs and symptoms. A typical course for the resolution of clinical effects supports the diagnosis. In cases where anticholinergic poisoning is strongly suspected, a physostigmine challenge may be used as a diagnostic tool. If administering physostigmine quickly reverses the delirium, it confirms the presence of an anticholinergic toxic syndrome. This can sometimes eliminate the need for additional neurodiagnostic tests, such as computed tomography scans or lumbar punctures. Furthermore, the physostigmine challenge offers both diagnostic confirmation and therapeutic benefits, as it can rapidly resolve delirium and reduce agitation. Routine toxicologic screens have limitations when it comes to detecting certain common anticholinergic agents, such as first-generation antihistamines, antispasmodics, and plant-based toxins. These agents are often not identified because standard toxicologic screening methods typically rely on immunoassays designed to detect common drugs of abuse. Some of these immunoassays, like those for tricyclic antidepressants, can produce false positive results if other anticholinergic drugs such as diphenhydramine or phenothiazines are present. Although quantitative assays are available for most anticholinergic agents, they are generally unnecessary for managing clinical cases. Additionally, these assays often cannot be performed quickly enough to provide useful information during urgent clinical decision-making. Laboratory studies in the evaluation of anticholinergic intoxication should be guided by the clinical situation. A fingertip blood glucose measurement is essential for any patient presenting with altered mental status. It is also important to assess electrolyte levels, including calcium, magnesium, and phosphate, along with a complete blood count. If there is concern for muscle breakdown, particularly in cases of severe agitation, hyperthermia, or excessive motor activity, measuring creatine kinase levels is advised. This may require repeated testing to monitor changes over time. Since many over-the-counter cough and cold remedies contain antihistamines, which can be co-ingested with anticholinergic agents, testing serum levels of acetaminophen and salicylates is crucial for identifying additional substances. For women of childbearing age, pregnancy testing should be performed as appropriate. Lastly, kidney function tests are necessary to assess the patient's renal status. An electrocardiogram is considered essential for all patients during the initial assessment. It should be repeated at regular intervals to monitor any changes. This is particularly important if the use of physostigmine is being considered or if there are signs of sodium channel blockade. The reason for this emphasis is that several anticholinergic agents, including tricyclic antidepressants and some first-generation antihistamines such as diphenhydramine, have sodium channel blocking effects. These effects can potentially lead to life-threatening heart toxicity. Key electrocardiogram findings to look for include widening of the QRS complex greater than 100 to 120 milliseconds, prolongation of the PR interval exceeding 200 milliseconds, or the presence of a higher degree atrioventricular block are also important indicators. Additionally, evidence of sodium channel blockade can be identified by a wide QRS complex, a terminal right axis deviation characterized by a deep S wave in lead eye and a tall R wave in AVR, as well as a tall R wave in AVR. Prolongation of the corrected QD interval can also occur, especially with certain antihistamines, such as diphenhydramine. This prolongation may lead to torsades de pointes, a form of life-threatening arrhythmia, which necessitates continuous electrocardiogram monitoring in patients considered high risk. The detection of sodium channel blockade on an electrocardiogram has significant clinical implications for patient management, particularly concerning the use of the medication physostigmine. The anticholinergic syndrome must be distinguished from many other conditions that can present with similar symptoms. For instance, sympathomimetic intoxication is characterized by diaphoresis or excessive sweating, in contrast to the dry skin typically seen in anticholinergic syndrome. Additionally, combined poisoning with anticholinergic agents and sodium channel blockers, such as tricyclic antidepressants, can mimic certain features of the syndrome. Over-the-counter medications containing antihistamines and acetaminophen are also common causes of such presentations. Salicylate intoxication, septic shock, and central nervous system infections like meningitis or encephalitis should be considered in the differential diagnosis. Other causes of delirium include metabolic disturbances such as hypoglycemia, hyperthermia, liver failure, uremia, hypercapnia, hyponatremia, and hypoxia. Withdrawal syndromes from substances like ethanol barbiturates and sedative hypnotics also play a role. Neuroleptic malignant syndrome, serotonin syndrome, as well as psychiatric illnesses such as schizophrenia and dementia can present with overlapping symptoms. Careful history taking and physical examination are essential in narrowing down the differential diagnosis. Routine laboratory tests and electrocardiograms are usually sufficient to aid in this process. However, clinical findings reported by patients can often be subjective and inconsistent. Consequently, the importance of objective measures and diagnostic procedures cannot be overstated, as they are critical in overcoming the challenges posed by diagnostic ambiguity. The management of anticholinergic intoxication involves a combination of supportive care, specific antidotes, and targeted interventions for associated complications. Because the potential for severe and life-threatening effects exists, it is essential to adopt a systematic approach to patient care. Most cases of anticholinergic syndrome are not immediately life-threatening and generally require observation along with supportive measures. Patients are at risk of self-harm or sudden deterioration due to seizures or respiratory distress, so careful monitoring is necessary until the major signs of toxicity resolve. In situations involving severe toxicity or where patients are unable to protect their airway, rapid sequence intubation should be performed to secure the airway. Regarding gastrointestinal decontamination, activated charcoal may be beneficial for a longer duration after ingestion than in typical overdoses owing to delayed gastric emptying and drug absorption. However, the use of activated charcoal should be cautious, especially in patients with altered mental status or a risk of seizures, unless the airway is mechanically protected. Urinary retention can lead to bladder distension, which may cause agitation. Managing this condition typically involves the placement of a Foley catheter. This intervention is particularly important for elderly men with prostate enlargement, as it also helps reduce the risk of urinary tract infections. Additionally, dilated pupils can cause sensitivity to light, known as photophobia. Dimming room lights can help alleviate discomfort caused by this symptom. Agitation and delirium are prominent features of central anticholinergic toxicity, and they require careful management to safeguard the patient and others. Benzodiazepines are used to provide sedation and help prevent seizures in patients who are agitated. A small dose, such as 1 to 2 milligrams of lorazepam, can be administered initially. This approach may help reduce the risk of seizures before considering other treatments like physostigmine. When addressing agitation or psychosis, benzodiazepines are generally effective, especially when administered with careful titration to achieve the desired response. Benzodiazepines have significant limitations when it comes to reversing delirium. Despite their sedative properties, these medications often do not effectively treat moderate to severe anticholinergic poisoning. They are completely ineffective at reversing delirium itself, and, in fact, using high doses of benzodiazepines can create a harmful cycle where ongoing delirium leads to increased benzodiazepine use, which may further prolong the condition. Research indicates that while benzodiazepines may cause a temporary decrease in scores on mental status assessment scales, they do not address the underlying causes of delirium. Furthermore, increasing doses of benzodiazepines to control agitation are linked to a higher likelihood of requiring intubation, a procedure to assist or control breathing. In contrast, the medication physostigmine has been shown to significantly reduce the rates of intubation compared to benzodiazepines. The treatment of choice for anticholinergic delirium is not benzodiazepines due to certain limitations. When a patient does not respond favorably to benzodiazepines, it is recommended to consider switching to alternative agents such as physostigmine or dexmedetomidine. It is generally advised not to simply increase the dose of benzodiazepines in such cases. Benzodiazepines are considered the primary or first-line anticonvulsants for seizures, especially those associated with anticholinergic or antihistamine toxicity. Examples of these medications include lorazepam, administered at a dose of 0.1 milligrams per kilogram intravenously, and midazolam, which is given at 10 milligrams intravenously or intramuscularly. In cases where seizures are recurrent or do not respond to benzodiazepines, further management may be necessary. This can include intubation and sedation with propofol or the addition of levetiracetam. Other second-line treatments for refractory seizures may involve the use of barbiturates or continued administration of propofol. While benzodiazepines are helpful for initial sedation and are central to seizure management in cases of anticholinergic toxicity, their ability to reverse core delirium is limited. Moreover, escalating use of these drugs can lead to complications such as the need for intubation. For resolving anticholinergic delirium, physostigmine proves to be a more effective and safer alternative, provided it is not contraindicated. Cholinesterase inhibitors, such as physostigmine and rivastigmine, are important in managing anticholinergic toxidrome because they counteract the effects of muscarinic receptor blockade. Understanding how they work when they are indicated, their benefits, and their limitations is vital for providing effective patient care. Physostigmine is a well-established antidote. It is a carbamate compound that reversibly inhibits cholinesterases in both the peripheral and central nervous systems. Its tertiary amine structure allows it to cross the blood-brain barrier, making it effective against central anticholinergic effects. This is in contrast to quaternary ammonium compounds such as neostigmine or pyridostigmine, which cannot cross the blood-brain barrier. By inhibiting cholinesterases, physostigmine prevents the breakdown of acetylcholine. This leads to an accumulation of acetylcholine, which can then compete with and antagonize the effects of muscarinic receptor blockers. Historically, physostigmine was first used as an antidote for poisoning caused by atropine in the year 1864. It gained widespread popularity during the 1970s and was even included in some medical coma cocktails designed to treat patients with undifferentiated delirium. However, its use declined after reports emerged of serious adverse effects, especially asystole in patients suffering from severe tricyclic antidepressant intoxication. Many of these cases resulted from administering physostigmine too rapidly or in patients who were not treated according to modern standards for tricyclic antidepressant overdose. Despite this controversy, physostigmine is currently experiencing a resurgence in popularity. When used correctly and in appropriate patients, it is considered safe and effective. Physostigmine is considered the treatment of choice for anticholinergic poisoning, especially when it is not contraindicated. Its primary role is in managing central antimuscarinic delirium, which is characterized by confusion, agitation, hallucinations, and purposeless movements. A challenge test with physostigmine can be used for diagnosis. If the delirium rapidly improves, it confirms the presence of anticholinergic toxidrome and may eliminate the need for additional neurodiagnostic procedures such as a computed tomography scan of the head or a lumbar puncture. Therapeutically, physostigmine effectively reverses both the peripheral and central manifestations of antimuscarinic toxicity. Studies have demonstrated that physostigmine is more effective than benzodiazepines in the treatment of anticholinergic delirium. In a comparative study, Physostigmine controlled agitation in 96% of patients and reversed delirium in 87%, whereas benzodiazepines only controlled agitation in 24% of cases and were ineffective in reversing delirium. Additionally, a prospective observational study found that the odds of achieving delirium control were 6.6 times higher for patients receiving physostigmine compared to those not receiving it. The use of physostigmine has also been associated with significantly lower rates of intubation, with only 1.8% of patients requiring intubation compared to 8.4% when benzodiazepines, either alone or in combination with other sedating agents, were used. This medication can serve as a benzodiazepine-sparing strategy, helping to avoid the risks associated with escalating benzodiazepine doses, which can perpetuate delirium and increase the frequency of intubation. Physostigmine has a short half-life, averaging approximately 16.4 minutes with a standard deviation of 3.2 minutes. Its effects on plasma cholinesterase last about 5 times longer, approximately 83.7 minutes with a standard deviation of 5.2 minutes. Patients generally experience full recovery within 3 hours of administration. The clinical effects of physostigmine may persist longer than its pharmacokinetic half-life. However, redosing is often necessary because the anticholinergic delirium it treats may outlast the drug's effects. For adult patients, the recommended dose is between 1 and 2 milligrams, administered intravenously over at least 5 minutes. In children, the dose should be calculated at 0.02 milligrams per kilogram of body weight, with a maximum dose of 0.5 milligrams per dose. It is important to have atropine readily available at the bedside to manage any potential cholinergic toxicity that may arise during treatment. Careful patient selection is crucial when considering the use of physostigmine due to the potential for adverse effects. It is contraindicated in patients with cardiac conduction abnormalities, such as an electrocardiogram showing a QRS interval greater than 120 milliseconds, a PR interval exceeding 200 milliseconds, higher degree atrioventricular block, or evidence of sodium channel blockade. This includes findings like a wide QRS complex, terminal right axis deviation, a deep S wave in lead eye, or a tall R wave in AVR. This caution is especially important because toxicity from tricyclic antidepressants involves sodium channel blockade, and physostigmine can worsen vagal effects, leading to decreased cardiac output and conduction problems. Physostigmine is also contraindicated in patients experiencing bradycardia, defined as a heart rate below 60 to 80 beats per minute, since anticholinergic toxicity typically causes an increased heart rate. Additionally, it should not be used in cases of airway compromise or seizures, such as in patients with frank coma who cannot protect the airway due to vomiting, those with epilepsy or recent seizures, or when there is a known ingestion of substances that promote seizures. Physostigmine is not suitable as an anticonvulsant medication. Patients with active respiratory conditions, specifically severe asthma exacerbations, should not receive physostigmine. Furthermore, it is contraindicated in individuals with structural obstructions in the urinary or gastrointestinal tracts, those with peripheral vascular disease, or in patients who are receiving therapeutic doses of choline esters or succinylcholine. Overall, careful consideration and thorough patient evaluation are necessary before administering physostigmine to avoid serious complications and adverse effects. Although physostigmine is generally safe when used appropriately, it can cause some adverse effects. These may include vomiting, slow heart rate, and seizures. An overdose of physostigmine can lead to an excessive buildup of acetylcholine at both muscarinic and nicotinic receptors, which can be harmful. Additionally, the preservative sodium metabisulfite found in physostigmine salicylate injections may trigger allergic reactions such as anaphylactoid responses in individuals who are sensitive. Rivastigmine is a medication that acts centrally in the nervous system. It is a type of inhibitor that binds in a pseudo-irreversible manner, meaning it remains attached for a significant period, and it does not compete with a natural substrate for binding. This drug specifically targets 2 enzymes, acetylcholinesterase and butyrylcholinesterase. It exhibits a higher degree of inhibition within the central nervous system compared to other parts of the body and is capable of crossing the blood-brain barrier, allowing it to exert its effects directly in the brain. Due to the limited availability of physostigmine, rivastigmine has increasingly been used in the management of anticholinergic delirium. This medication offers a longer duration of action compared to physostigmine. Rivastigmine is available in the form of an oral capsule and a transdermal patch, with no preparation available for intravenous administration. Regarding its efficacy, a series of case reports has suggested that oral rivastigmine may be more effective than the transdermal patch in resolving anticholinergic delirium. Patients treated with the oral form generally required less additional sedation or physostigmine administered via injection. The difference in effectiveness is believed to be due to the pharmacokinetic and pharmacodynamic differences between the two formulations. Specifically, oral rivastigmine achieves a higher maximum concentration in the blood and results in a faster peak in acetylcholinesterase inhibition compared to the transdermal patch. In one series, the median time to resolution of delirium was reported as approximately 2 hours for patients receiving oral rivastigmine, whereas it was about 5 hours for those using the transdermal patch. The pharmacokinetics and dosing of rivastigmine vary depending on the method of administration. When taken orally, the time to reach peak plasma concentration is approximately 0.8 to 1.4 hours. The drug's half-life ranges from 1.3 to 1.9 hours. Peak inhibition of acetylcholinesterase, an enzyme targeted by rivastigmine, occurs between 2 to 6 hours after administration and can last up to 8.5 hours. Based on its pharmacological properties and observed safety profile, an initial oral dose of at least 6 milligrams is recommended. In contrast, transdermal rivastigmine reaches its peak plasma concentration around 8 hours after application. The inhibition of acetylcholinesterase is sustained over the entire duration the patch is worn, with a slower onset of peak inhibition occurring between 8 to 16 hours depending on the dose. A transdermal patch delivering 9.5 milligrams per 24 hours may be appropriate in cases of severe delirium where oral administration is not feasible or when physostigmine, an alternative drug, is unavailable. For ongoing management, repeating oral doses every 8 hours or using the transdermal patch can help maintain consistent rivastigmine concentrations in the body. In a particular case series, the administration of rivastigmine did not result in bradycardia or gastrointestinal symptoms. However, it is important to consider individual patient histories when evaluating potential adverse effects. For example, one patient with a history of epilepsy experienced a seizure after receiving both physostigmine and transdermal rivastigmine. This emphasizes the importance of carefully reviewing a patient's medical background before prescribing these medications. In managing agitation, especially within the challenging context of anticholinergic toxicity, dexmedetomidine proves to be a valuable pharmacological option. It is distinguished by its unique mechanism of action and side effect profile. Dexmedetomidine is a potent alpha-2 adrenergic receptor agonist. Its primary action occurs in the brainstem, where it activates postsynaptic alpha-2 adrenergic receptors. This activation inhibits sympathetic output and results in sedation. Unlike typical sedatives, dexmedetomidine affects noradrenergic neurons in the locus coeruleus, leading to sedation. Additionally, it influences receptors in the nucleus tractus solitarius and the ventrolateral medulla, which contribute to hypotension and bradycardia. This mechanism of action is distinct from other agents that increase adrenergic activity. Managing agitation in anticholinergic toxidrome can be particularly challenging. Agitation is a common manifestation and is often accompanied by delirium, hallucinations, incoherent speech, and picking movements. While physostigmine is frequently the preferred treatment when there are no contraindications, dexmedetomidine provides unique advantages as an additional or alternative therapy. This approach offers a flexible option for clinicians dealing with such cases, ensuring better management of the symptoms. Benefits of dexmedetomidine include its titratable nature and ability to spare respiratory function. Since dexmedetomidine can be precisely adjusted, it allows healthcare providers to tailor sedation levels while minimizing the risk of respiratory suppression. This makes it a safer option for airway management compared to increasing doses of benzodiazepines, which can depress respiration. Additionally, dexmedetomidine has a short half-life, reducing the likelihood of oversedation. Unlike benzodiazepines, it may also be less likely to contribute to prolonged sedation or delirium. These characteristics make dexmedetomidine a valuable agent in clinical settings requiring careful sedation management. The main side effects of dexmedetomidine are slow heart rate and low blood pressure. These effects can be beneficial for patients with anticholinergic poisoning who often experience rapid heart rate and high blood pressure. Additionally, dexmedetomidine may help reduce heat production and improve hyperthermia, which is a common symptom of anticholinergic poisoning. Although the evidence supporting the use of dexmedetomidine is not as extensive as for some other medications, there is an increasing amount of research indicating its potential benefits. For example, it has been used as an additional treatment for anticholinergic toxicity caused by diphenhydramine. In this context, it has helped to alleviate symptoms such as agitation, psychosis, and rapid heart rate. Moreover, dexmedetomidine may decrease the risk of respiratory depression that can occur with high doses of benzodiazepines. Dexmedetomidine has certain limitations that are important to consider. It typically requires patients to be admitted to an intensive care unit for continuous monitoring because of its effects on the cardiovascular system. Additionally, it takes some time for the medication to reach its maximum effect, which makes it less appropriate for the emergency treatment of severe and sudden agitation. These factors should be taken into account when considering its use. Dexmedetomidine is particularly useful in specific clinical scenarios. It is indicated when physostigmine is contraindicated, such as in cases involving cardiac conduction abnormalities. The medication is also beneficial for patients experiencing complex intoxications, especially those involving both anticholinergic and sympathomimetic substances. Additionally, dexmedetomidine is effective for managing difficult-to-control agitation, particularly when multiple boluses of other sedating medications are required on an as-needed basis. Many antipsychotics have anticholinergic activity that could exacerbate the toxidrome. Haloperidol, while used to calm delirious patients, has mild anticholinergic properties and concerns about QTc interval prolongation, warranting monitoring if used. Intubation is recommended in several important scenarios when managing agitation and anticholinergic toxicity. One key situation is when a patient is in a straightforward coma and unable to protect their airway. This inability increases the risk of aspiration, which is a concern because medications like physostigmine can rarely worsen the situation by inducing vomiting. In cases of severe toxicity, such as extensive anticholinergic poisoning, intubation may become necessary, especially if the patient experiences significant seizures, dangerously high body temperature, or is in a coma. Additionally, if excessive sedation, for example from high doses of benzodiazepines, results in respiratory depression or impairs breathing, intubation should be performed to secure the airway and support ventilation. Finally, in instances where seizures recur repeatedly and do not respond to initial treatments like benzodiazepines, intubation followed by sedation with agents such as propofol may be required to stabilize the patient. The benefits of intubation are significant when it is appropriately indicated. It helps in managing the airway by providing protection, which is a fundamental aspect of critical care, especially for patients with altered mental status. Intubation allows for controlled sedation and mechanical ventilation, making it universally effective in managing severe agitation and ensuring the safety of the patient. Additionally, sedation agents such as propofol are frequently used during intubation, offering strong protection against seizures. Despite its critical role in airway management, intubation carries inherent risks and can be associated with complications. The procedure itself may pose risks to the patient, including potential procedural complications. Additionally, prolonged mechanical ventilation, which is often necessary after intubation, can lead to side effects such as the development of delirium and an increased risk of pneumonia caused by the ventilator. It is important to note that intubation is rarely required for cases of pure anticholinergic intoxication, which highlights the importance of considering less invasive strategies whenever feasible. Seizures caused by anticholinergic toxicity are typically treated with benzodiazepines, which are considered the primary anticonvulsant agents. When seizures are refractory and do not respond to initial treatment, barbiturates or propofol may be used as second-line options. It is important to note that phenytoin should be avoided in these cases, as it has the potential to worsen sodium channel blockade and thereby exacerbate seizure activity. Additionally, physostigmine is not recommended as an anticonvulsant therapy in this context because it has limited efficacy and may increase the likelihood of seizures. The cardiovascular effects of certain medications or substances can include tachycardia and hypertension. These symptoms are generally mild and well tolerated. When agitation causes an elevated heart rate, addressing the agitation directly is considered the most effective approach. It is advisable to avoid using beta blockers initially, as they may hinder the subsequent use of medications like dexmedetomidine or physostigmine. Hypotension may also occur and typically responds to fluid resuscitation. In cases where there is evidence of sodium channel blockade, such as with diphenhydramine or tricyclic antidepressants, sodium bicarbonate is the preferred treatment. It should be administered in boluses, generally at doses of 1 to 2 milliequivalents per kilogram, to overcome impaired sodium conduction. Prolongation of the QT interval and the development of torsades de pointes, a specific type of abnormal heart rhythm, can be caused by some antihistamines like diphenhydramine. Monitoring the QT interval is essential in these cases. Maintaining magnesium levels above 3 milligrams per deciliter and potassium levels above 4 milliequivalents per liter can help reduce the risk of arrhythmia. Intravenous magnesium sulfate is effective in treating torsades de pointes. Other treatment options include medications like isoproterenol and electrical pacing of the heart. Additionally, intravenous lipid emulsion therapy has been reported as a rescue treatment in cases of diphenhydramine-induced ventricular tachycardia that does not respond to sodium bicarbonate. Rhabdomyolysis can occur as a result of severe agitation, high body temperature, or excessive motor activity. To treat this condition, early and liberal administration of intravenous fluids is recommended. Hyperthermia, or dangerously high body temperature, requires active cooling measures such as misting and fanning, as well as the use of cooled intravenous fluids. Additionally, benzodiazepines may be administered to manage shivering associated with hyperthermia. Several agents, particularly first-generation antihistamines such as diphenhydramine and tricyclic antidepressants, inhibit both muscarinic acetylcholine receptors and cardiac sodium channels. In cases where these agents are involved, the most dangerous effects are often related to sodium channel inhibition. Therefore, management should focus on addressing sodium channel blockade, commonly with the administration of hypertonic bicarbonate. Physostigmine is generally considered to be relatively contraindicated in this situation. However, some experts recommend its use in cases of antihistamine poisoning where the electrocardiogram shows evidence of sodium channel blockade. Special considerations are necessary for certain patient populations. Elderly patients tend to be more susceptible to developing altered mental status when exposed to anticholinergic agents and are at higher risk for central anticholinergic syndrome. Young children may experience more respiratory complications, central nervous system stimulation, anticholinergic effects, and seizures. Anticholinergic poisoning is a very common form of intoxication, accounting for approximately 15 to 20% of all cases involving acute poisoning that present with delirium. Agents that cause anticholinergic effects include medications that primarily act as anticholinergics, such as atropine, scopolamine, and certain medications used to treat bladder spasms. Additionally, some drugs with mixed effects, such as first-generation antihistamines like diphenhydramine and tricyclic antidepressants, are frequent sources of exposure and can cause severe toxicity. The main toxic mechanism involves the competitive blocking of acetylcholine at muscarinic receptors, which are found in both the central nervous system and the peripheral nervous system. This interference produces the characteristic signs and symptoms of anticholinergic toxicity. These symptoms are often summarized by the mnemonic mad as a hatter, blind as a bat, red as a beet, hot as a hare, dry as a bone, full as a flask. The key manifestations of the condition include effects on both the central nervous system and the peripheral systems. Central nervous system effects can manifest as agitated delirium, hallucinations, confusion, incoherent speech, and in severe cases seizures and coma, sometimes described as feeling mad as a hatter. These neurological symptoms can persist even after peripheral effects have subsided and may occur without any peripheral signs. Peripheral effects include pupillary dilation, also known as mydriasis, and blurry vision, often described as being blind as a bat. Skin may appear flushed, resembling red as a beet, and individuals may experience hyperthermia or feeling hot as a hare. Additionally, dry skin and mucous membranes termed anhidrosis or dry as a bone are common, along with urinary retention, sometimes described as being full as a flask. Tachycardia or rapid heart rate can also be observed. Notably, the presence of dry skin is an important diagnostic feature that helps distinguish this condition from sympathomimetic toxidromes, which typically involve sweating. It is important to recognize that severe and life-threatening complications associated with large ingestions of certain agents often result from their physiological properties rather than solely from their anticholinergic effects. For example, tricyclic antidepressants and some first-generation antihistamines can cause cardiotoxicity and increase the risk of seizures due to their ability to block sodium channels and/or inhibit potassium efflux. The diagnosis of such poisonings is primarily based on clinical evaluation. Routine toxicologic screens may not detect many anticholinergic agents. However, a physostigmine challenge test can be used diagnostically. This test involves administering physostigmine to rapidly reverse delirium, thereby confirming the presence of an anticholinergic toxidrome. An electrocardiogram is also essential as it helps identify cardiac conduction abnormalities, including QRS widening or other signs of sodium channel blockade, that have significant implications for management. Management involves providing general supportive care, which includes protecting the airway, managing hyperthermia, and inserting a Foley catheter for urinary retention. When addressing agitation and delirium caused by antimuscarinic toxicity, physostigmine is considered the treatment of choice if there are no contraindications. This medication is a centrally acting cholinesterase inhibitor that effectively reverses both central and peripheral symptoms, and it is superior to benzodiazepines for reversing delirium. Additionally, physostigmine can reduce the need for intubation. Contraindications for physostigmine include cardiac conduction abnormalities such as a QRS duration greater than 100 to 120 milliseconds or signs of sodium channel blockade, as well as bradycardia, active asthma, and coma where the patient cannot protect their airway. Benzodiazepines are mainly used as anticonvulsants for seizures and can provide initial sedation. However, they are not effective at reversing delirium, and increasing their doses may prolong delirium and raise the risk of intubation. An alternative treatment includes rivastigmine, another cholinesterase inhibitor available in oral or transdermal form. It is used for anticholinergic delirium, particularly when physostigmine is unavailable. Dexmedetomidine, an alpha-2 adrenergic receptor agonist, can be helpful for agitation when physostigmine cannot be used, as it provides sedation without causing respiratory depression. It may also assist in managing rapid heart rate and hyperthermia, although its use requires intensive care monitoring. It is important to avoid antipsychotic medications that have anticholinergic properties, as they can worsen the toxic effects. For life-threatening cardiovascular effects such as widening of the QRS complex or ventricular tachycardia caused by sodium channel blockade, treatment with sodium bicarbonate is recommended. Magnesium sulfate is used to manage prolonged QT interval and torsades de pointes. Intubation is indicated for protection of the airway in cases of coma, severe toxicity with marked seizures, or respiratory depression resulting from excessive sedation.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.